By now, you've heard about opioid use disorder prevention and treatment from a variety of medical professionals. This segment presents OUD from a very different vantage point: the patients. The next 30 minutes will highlight the need to really listen to your patients and listen without judgment. So sit back and focus in. You're about to meet two very different people who lost themselves to the disease of addiction and found themselves again through the use of buprenorphine. They both credit that treatment option and their doctor for helping restore their lives.
Hey, my name is Blaine Malachi.
My name is Tammy King.
My mother was a drunk and my father was a drunk. And I also became a drunk.
Absolutely wonderful childhood, wonderful college and graduate school.
Addiction is a disease. It's a disease like cancer. It's a disease now. It's been the Surgeon General and everybody else say addiction now is a disease.
I would never expect me to be going to a street corner to get drugs. But I did.
I'm Larry Greenblatt, and I'm a general internal medicine physician at Duke, and I've worked there now for a little over 26 years. I am waivered to be able to prescribe buprenorphine, and also have been heavily involved in the opioid safety efforts at my institution. I became the physician lead for what we call the Opioid Safety Task Force, and this got started in the early spring of 2013, and we came up with a set of policies and procedures, some documentation tools. We did a lot of education and outreach, went to countless grand rounds and divisional meetings, and talked about expectations around safety with prescribing opioids, naloxone rescue kits, the role of urine drug testing and the like. And something we certainly saw was that there was a wide range of how opioids were being used throughout the health system, and not necessarily a lot of enthusiasm for changing clinical practice. In North Carolina, we had some legislation passed that was enacted in 2018, and if you're a North Carolina medical student, you might have heard of the STOP Act, and that required, for example, 5 days or less as an initial prescription for managing acute pain. We saw on the Opioid Safety Committee, not only did we need to change the way we managed people on prescription opioids, but we needed to have the capacity and the readiness that when somebody was in need of treatment for an opioid use disorder, that they got it right away. I think that's critical if we're gonna really make a difference in this crisis.
Well, if I'm gonna tell my story, I have to start from the very beginning. My mother was an alcoholic, my father was an alcoholic, and my mother drank alcohol the whole 9 months while she was carrying me. When I started recognizing that I was living in a domestic situation, I was about 6 or 7 years old. I remember times when I was 5, 6 years old, and my mother would come out the house while all the other little kids was playing, my friends and all, and she would come get me and want me to walk her to the liquor store, and she was staggering. She couldn't even hold herself up. She could just hold on me, and I'm a little boy, and I'm guiding her to the liquor store to get her liquor. And my dad, for instance, I watched my dad, it started like this for him every day. 8 o'clock in the morning, he started out with a pint on a Sunday. 8 o'clock in the morning, he started out with a pint. And we would leave and go somewhere, we would come back. By 12 o'clock, he would have that fifth going on. And not completely there yet. And at 12 o'clock, he was going to get another one. And at 5 o'clock, he had that gallon. And after that gallon was gone, then that's when all the domestic stuff took place in my house. So I developed all these behavior problems at an early age. I got tired of the stuff that was going on in my home. So I decided to leave at 14. So when I left at 14, I hit the streets. That's when I met my first wife. She was 13 years old, and I was 14 years old, and she was having a baby. That was our first child. But with her, I ended up having 5 kids, back to back, back to back, back to back. So when I was at the age of 21, I had already had 5 kids of my own. I recognized that my behavior was beginning to be dangerous and was dangerous because I looked at my father for years. I looked at my father stuff progressed. At the age of like 24 years old, my first wife, she decided that she had enough, and she left me. And she divorced me. That's when I ended up in a mental institution. I ended up suicidal and in a mental institution. I was taught that you had a choice. I felt like my mother didn't have to be like that. My father didn't have to be like that. They just wanted to do that. That's how I felt. That was one of my hang-ups. I started discovering different drugs and dealing with different drugs and having a lot of problems like my mother and father was having. I started having domestic violence issue with my girlfriend. We did a lot of arguing, a lot of fighting, a lot of calling the cops, a lot of leaving, a lot of the kids being scared and afraid, and me end up being arrested or in jail. The first time I tried heroin, I was like 27 years old. I was able to escape a lot of pain, a lot of hurt, a lot of things that happened to me in the past, and I loved it. Sadly to say, but I did. 2002, 2003, they was trying a new drug for people that was addicted to heroin. A trial study. It was a 2-year program. You had to get a psychiatrist and a psychologist, and you had to graduate in the end. And you had to try this new drug that they had, which is known as Suboxone now. And when they gave it to us, it did exactly what they said. For me, it stopped the craving. It stopped that. And a craving is, man, let me describe a craving for you for a minute. You can't think about nothing else in the world. You can see the most beautiful woman, the most beautiful car, whatever is your fantasy. You could see that, have that one thing, but I'm telling you, when it comes to a craving of using narcotics, nothing seems to stop you from thinking about nothing but using that drug. That part of my addiction stopped for me, and it was unbelievable. Like, I couldn't believe it. I started finding out that I was suffering from things like PTSD, bipolar disorder, anxiety. I had a little bit of ADHD, and the post-traumatic stress that I was dealing with was from my childhood. And I couldn't believe it. I said, man, I'm almost 30-some years old and I'm suffering from something that happened to me I found out that I was suffering from that, still suffering from that through that Suboxone program. So I went to my primary care doctor and I met Dr. Greenblatt. He said to me, if you be honest and I give you a chance, are you gonna straighten yourself out? That's all I wanna know. And something, the way he said it, I said, yo, this is it. Yeah, I'll be honest to you. I'm not gonna get high. I just wanna get back on the clinic. I just wanna get my Suboxone so I could go on. And he said, well, you trust me and I trust you, and come back and see what I do. And I had to wait about a week, but he did what he said he could do, and I've been clean ever since.
In 1995, one of my first encounters with pain pills was due to shingles. At that time, I was prescribed 100 Percocets. I thought, okay, we'll see how it goes. And I was probably addicted in a week. It did not take any time for me. I was one of those folks that got an immediate buzz, a high, so to speak. So that's how things all started. Some people, it makes sleepy, drowsy, sick. They have allergic reactions. Not me. I just felt it was a great feeling. I really liked it. And I functioned like that for about 20 years. Every primary care physician that I had would give me pain pills, whether it was a shoulder problem I was having, a foot issue I was having, and doctors weren't communicating with other doctors. So the orthopedic doctor would prescribe pain pills for my foot issue or my shoulder issue. And then if I had another issue, I would easily be prescribed another prescription. The high from the pain pills, that stopped. That stopped probably 2 years into it. I would not get the experience of a high from the drug anymore. Just to feel normal, I had to have it. I believe the longest I ever went during about a 20-year period of abuse was about 36, 37 hours was the longest I was ever able to go. It's an undescribable craving. You've got to have it. You will do just about anything. You would take, as I did, pain pills from my grandmother. It takes over your whole mind, your whole body. I even thought about slamming my hand in a car door. Thought about falling down steps on purpose, just so I could get the pain pills. There was a time when I was counting pain pills, running out of pain pills, knowing things were changing in society with opioids and with the doctors prescribing them. I could tell the new doctors coming out of school had a much different perspective than some of the ones I had been seeing. And I did. I thought of harming myself. Suicide was a thought. Fortunately, worked through that, but the thought was there. When that day came, April 12th, 2016, I was tired, hit low, bottom, and I said, I've got to do something. I remember the day at about 3 o'clock in the afternoon, and we'd gotten an electronic medical record by this time, and I knew the only way that I was going to be able to come clean, so to speak, with my primary care physician was to send a note in my chart, an electronic message, so to speak, because I knew as soon as I hit send, I couldn't take it back. So, got down on my hands and knees, said, God, what do I do? Typed the message, and that was a Sunday afternoon, I believe, and I heard from her at 9 o'clock the next morning. Come to my office. Anytime you can get here, come. She was very, very open with me. It said that she understood the cravings and how bad they were, but she knew a doctor at Duke, Larry Greenblatt, that was an opioid specialist, and she would do everything in her power to get me in to see him. That was Monday, and by Wednesday I had met with Dr. Greenblatt, had a treatment plan set up with him, and went out on FMLA because I didn't know how I was going to do. I thought being addicted for 20 years, I might wind up in the hospital. I could tell from the moment that I met Larry that he was going to get me out of this. I felt confident when I went to see him. Of course, Dr. Kappa had talked about him and all his background. I did the research on him, read his articles. So I knew that I was going to get help. I did not know what he was going to do about the cravings, because that was just something that was so mind-boggling. What can be done to stop this without putting me in a cell and locking the door? So Dr. Greenblatt started explaining some of the treatment options and mentioned Suboxone as being one, and we went that path. I didn't know when I first went to see him if I needed, since I'd been taking pain pills for 20 years, I wasn't sure if I needed to be in an inpatient facility. Could we do this outpatient? I didn't know. But he assured me that he thought stay in close contact with one another, that we could do this on an outpatient basis, and that worked magnificently.
for both Tammy and for Blaine, they really have found buprenorphine to be their best treatment strategy, and that is one of the 3 different medication-assisted therapies or medication-assisted treatment that are available to individuals with opioid use disorder. Other treatments are methadone, and methadone can be used as a pain medicine, but it is commonly used as a treatment for opioid use disorder. And that has to be done through what's called an opioid treatment program, or OTP. Some people call them informally a methadone clinic. And typically in those settings, people come in every day and they're given a large dose of methadone once a day. And that's enough to stave off cravings and withdrawal for 24 hours. And those programs work well for someone who needs the structure and need frequent contacts. And really our overall strongest evidence for efficacy of treatment is with methadone. We know methadone dramatically reduces the risk of opioid overdose death and of death from any cause. It also reduces the risk of getting HIV, hepatitis C, of committing crimes. There's really any number of really important health outcomes that are improved with methadone. So we need to remember that as an option. Another option that people can use is naltrexone. Naltrexone is a pure opioid blocker, and that is given as a monthly injection. There is an oral version. It doesn't work very well as a treatment for opioid use disorder. So typically it's going to be given as a monthly injection. And if a person is on naltrexone and they use opioids, it will block the effects completely. The challenge with naltrexone is individuals in treatment often will fail to continue on with it. So the dropout rates in a number of studies are quite high. A person might come in for their first injection, maybe their second, but by the third, the majority aren't showing up anymore. And if you're not taking the treatment, it's not going to work. Another challenge with naltrexone is an individual needs to be completely abstinent from any opioids for about 4 to 7 days before beginning on it. Otherwise, the naltrexone will push them into a withdrawal, which is very unpleasant. So that first 4 to 7 days can be very challenging for a person who is thinking about getting off of opioids. And often there's ambivalence, it's hard, and that period of time, a lot of people will relapse. Another alternative, and it's the one that is most commonly used in the United States, is an abstinence-based approach. And this is more like support groups, counseling, and the like, but without any medication. And the problem with abstinence-based therapy, well, there's a couple of problems, 2 big ones. One is that it doesn't work very well. People at 1 year, only about 5 to 10% of people embarking on an abstinence-based approach are still going to be sober at the end of a year. The other problem with an abstinence-based approach is if a person does relapse, they have lost much of their tolerance for opioids. And then when they go back to using, people tend to go back to using about what they used to in terms of milligrams or the amount of heroin. And often that's a dangerous amount because they're much more sensitive, less tolerant, and they can then overdose on a dose that used to be safer for them to use. And people can, relapse and then overdose and die from an abstinence-based approach. You may recall that buprenorphine is it has both agonist and antagonist properties. And as an agonist, it's really only a partial agonist. So if a person were to overdose on buprenorphine, they're only going to get so much opioid effect. And an actual death from buprenorphine overdose is exceedingly rare unless there are other substances in the person's system. So that makes it a safer drug. It also is enough of an agonist that it takes away the cravings that people might have, and it helps prevent withdrawal. It has antagonist properties as well, and that's important. If a person is using buprenorphine and on it regularly, if they were to have a relapse, let's say a friend shows up and says, hey, I got some heroin, why don't we use that like old times, and they use it, that person is not going to get really any effect from the heroin. It would essentially be blocked. Yeah, so opioid use disorder, like other addictions, isn't necessarily something that a person chooses to develop. There are people who can use opioids intermittently, recreationally, and really never develop the addiction piece. Some people do. We don't fully understand why that is. And that addiction, when the person is in the throes of it, strongly drives their compulsive behavior. It forces them to take risks, to do things that might be destructive to them personally, to their family. They might lose economic opportunity, sometimes maybe end up homeless as a result. But it's the disease that's driving all of those behaviors, and a person loses control to the disease, and that's what the nature of addiction is.
There is certainly a stigma associated with pain pills. We all know that now. I didn't want anyone to know because of the stigma. Physicians have stigmas as well.
Stigma continues to be a big issue, even among health professionals, when it comes to opioid use disorder. I think, if an individual shows up for care and they're on buprenorphine, and let's imagine they're at a dermatologist's office or an orthopedist's office, they might be made to feel uncomfortable about, oh, you have a history of addiction, and oh, look, you're taking this treatment, and they might be labeled as, oh, this is a person who's a drug addict, or this is a person who somehow has a weakness that they caved into this compulsion to use drugs. When in fact, we really need to think of opioid use disorder for what it is, which is it's a brain disease. It's a chronic relapsing brain disease with changes caused by the opioids themselves. No one ever wakes up in the morning and thinks, I think one day I'm going to become an opioid addict. That's just not how it works,
Okay, so one of the things I've always heard, once an addict, always an addict. That is so untrue. That is so untrue. Because they don't understand, an addict deserves, after all they've been through, because when we out there using, we hurt many people, but most of all, we hurt ourselves. We hurt ourselves 300 more times than the chain we stole from our kids or whatever. We gotta live and suffer with that for years.
One thing that I think is very important for the physician on the first encounter they may have with somebody, they've done their research hopefully on the patient before they walk in the room for the first time. But you can't go in the room headstrong. You've been on pain pills for this amount of time. We're taking you off, or we're starting to taper now. That is the worst message that a doctor could give.
When a patient comes in for treatment, it's really important that you, as the treating provider, develop a relationship with that patient. And that's going to be one where you demonstrate interest, where you develop trust, where you're genuinely listening to what that person has to say and without judgment. And they may tell you terrible things that they've done in the past, stealing, lying, using all kinds of drugs, showing up to work intoxicated and the like, but you need to hear it and you need to help that person, and you need to know that person needs to know that you care about them, and then you just genuinely need to do that. Demonstrate that this is something that you really care about and you want to help. And that relationship is really vital. It's not just the medication, I know that there are Suboxone programs that really are taking advantage of these folks, and they will set up 5-minute visits, and it's a very distant kind of relationship. And it's just, here's your medicines, go pee in a cup, and we'll see you back in 2 weeks.
If I'm doing these drugs for so many years, right, don't expect me to come in there and be clean overnight because you handing a Suboxone to me. It's more to it than that. It takes a lot of therapy, a lot of people caring. For me, a lot of people, have to still support. You need that support.
Even if you never treat a single person for opioid use disorder, it's good to welcome these folks into your practice, to recognize they look and they'll act just like everybody else who comes to see you. They might be taking buprenorphine, but they may be very much in need of your surgical care or your medical care or whatever it is you're going to be able to provide them. And, talk to them about, where they've come and about their journey, and, make them feel good about it. It's a hard thing to do. Sometimes when I talk to clinicians about the idea of getting their waiver and treating some patients in their practice with opioid use disorder, they kind of look at me like, really? Why would I want to bring people with addiction into my office? It's going to be obvious that they're different, and that they're going to change the milieu in the waiting room, and they might harass the staff and the like. When in fact, I would tell you that my patients with opioid use disorder, some of them own their own business, all of them work. These are people that are really getting on with their life, and they look and act just like anybody else. I will tell you that their no-show rate for appointments is very low. They make and keep their appointments. They certainly come on time. They're really some of my really most enjoyable patients to care for. They're really appreciative of the treatment, and they really share with me their success and about how much their life has changed. And it's, for me as a clinician, I feel great, and they contribute very positively to the atmosphere in the clinic where I work. It's really important for us to listen to our patients, to ask them, be open to whatever answers they provide, and listen to what they have to say about, what their life has been like, how they ended up, developing a problem with opioids, how they've coped, what maladaptive things they've done, what things they've done that have been helpful, and how it's been really difficult for them at times. And we have to be open and receptive, non-judgmental, and just hear these things. If somebody tells you, I used to steal from my grandmother so I could buy heroin, you have to realize that person doesn't feel good about that. They're deeply ashamed of that behavior, but the addiction drove them to do it. They were so desperate for the drugs, they might have done something that they really now regret. And we have to hear that and not add to their shame or their misery, but rather just to hear it, support it. You don't have to, condone it. You don't have to tell them, oh, I think that's great, I would have done the same. But rather, to be open to just listening with a receptive ear and a genuine interest in what people have to tell you. It'll make you a better doctor. It'll make you a better person just to learn about life from someone who's had a very different life than I expect that you've lived.
If you're a doctor and you're trying to get involved with substance abuse, the first experience you want to get is from a person that's abusing substance. That's quite naturally. You're going to get the experience from them more so than anybody else.
As a physician, you need to recognize that you might have stereotypes or expectations of what a person with opioid use disorder is like, and we need to move beyond that. We need to be open-minded and flexible and recognize that this is a disease that affects people. We need to be open to hearing their perspectives and also open to treatment, and to recognize that this is a difficult and dangerous problem that a person might have, and you can make a big difference either as their treating provider or as just someone who's willing to hear about it and to help them find treatment in your community where you practice.
I've seen miracles. I've seen, there's thousands of people that used to use that's not using.
It's interesting to see when a person gets on treatment, particularly buprenorphine, in a week or 2 weeks or 3 weeks, their brain starts to work differently. They start to reflect differently, they feel differently about things, and you'll see this big change in their behavior. They come in, they'll start to talk to you about, gee, I've worked things out with my friends, or I'm applying for a new job, or I'm going to go back to school. Things that never would have been possible when they were in the throes of addiction. And it's a really rapid change, and people just start to feel normal and start to function in the way that they used to prior to the opioid use disorder, essentially hijacking their brain. And it's, as a clinician, it's tremendously rewarding, but you can really see a before and an after.
I would absolutely recommend it as a treatment option. I think the combination of committing to it, letting my employees know, taking FMLA, going in and seeing Larry probably once every 2 weeks for the first few months, I think that did the trick.
It's really important, and ultimately for you as a treatment provider, you're going to feel really good if you can help a person to get away from their addiction and into recovery.